and that's better shown in this graph here. Yeah. So this graph was like in one of the slides, but it's from a reading that wasn't highlighted, but you could easily just like the tag, like the annotation like on the side gives like the article and like date and stuff. So if you just copy that and paste that into Google, you can like read the whole paper and get more information. But basically this graph shows the amount of urea that's present in the blood on the y-axis over time. So these patients were undergoing hemodialysis 3 times a week, and you can see that, I don't know if you can read, it says that they underwent hemodialysis on Monday, Wednesday, and Friday. So at those dates you see that there's lower levels of blood urea, and then on the days that they didn't undergo hemodialysis, the levels of urea in the blood increased.
Does this graph make sense to everyone?
Yeah, so yeah, you just note the sharp increases when the body is undergoing dialysis, and then the sharp increases when the body isn't connected to the dialyzer, and then the decreases when the body is connected. So peritoneal dialysis is another type of treatment for kidney disease, and it provides a larger surface area for exchange. And the molecule glucose is what establishes a concentration gradient that allows for water to be removed from the blood. So within peritoneal dialysis, there are 2 types, continuous ambulatory PD and continuous cycling continuous cycling PD. So the first type, CAPD, occurs throughout the day, so that's kind of like an obstacle for the patient when like they're connected to this machine all day. And it's like the dialysate fluid just sits in the abdomen for like periods of time, and then it just gets removed like, I don't know, like 3 to 4 times a day. And then CCPD, which is like a more recent type of peritoneal dialysis, can be done overnight. So it's the machine sort of automatically funnels like dialysate fluid into the abdomen and then removes it 3 to 5 times per day. So that's obviously more preferable if you're a patient, since that whole process can just happen while you're sleeping. And then it's important to note that with peritoneal dialysis, each time you do perform an exchange, you're exposing your abdomen to bacteria and like all different types of microorganisms from the environment, and that can develop into peritonitis, which is the infection of the abdomen. So it's really important that patients and other like nurses or patient helpers are taught aseptic techniques to sort of keep this procedure as clean as possible and minimize the risk of infection. That's it. Yeah.
I want to get last a diagram of peritoneal dialysis and hemodialysis. Would you be able to would you be able to list the steps?
No, you don't have to be able to list the steps. Yeah, no, definitely not. I think it's just more important to know like the differences between the two. So in hemodialysis, you use either the fistula or the graft to connect the artery to the vein, and like that fistula is connected to the dialyzer, and like that's how blood is being filtered and unfiltered. And then with peritoneal dialysis, it's kind of like you're dumping dialysate fluid into the abdomen, letting it sit there, and then that's how the blood is being filtered. Yeah.
How do you empty out the dialysate in the peritoneal dialysis?
You do.
Yeah, you do, but yeah.
2-minute grains.
Yeah.
That's why there's such a high risk of infection.
Because you're like constantly like taking stuff out of your body and like putting new stuff in.
It's a lot of tubing. Questions? Oh, they did just one.
Okay, so I'm going to go over prosthetics, which you guys learned today, so it should be pretty fresh. So this is just a basic definition of prosthetics. It's the science of replacing a limb with a non-functional or functional device. And as she said today, it kind of goes through a spectrum, over the course of the past 20 years, from something that was non-functional and just used as a replacement to something that can actually be used in everyday life to pick up objects and walk. Okay, so these are the reasons for needing prosthetics. You should know the difference, not know the difference, but know the types of reasons for each of the developed and developing countries. Congenital defects or birth defects, circulation, which goes into atherosclerosis, and CAD, which is coronary artery disease. And so what happens with coronary artery disease is you have ischemia of the lower extremities, so basically not enough oxygen, not enough blood is getting to your peripheral system, and you can eventually have ischemia in the legs leading to lower leg amputation. So know about that, and also know about diabetes. Diabetes, I don't know if she mentioned this one, but it can lead to foot ulcers, often because they don't have sensation neuropathy in the bottom of their feet and in their lower extremities, so they can get an infection, not know about that infection, which can progress and eventually lead to lower extremity amputation. Okay, so she has this slide. Know them. They're in red. She went over them multiple times in class today. Successful prosthetics, comfortable to wear, easy to put on and off, lightweight, durable, cosmetically pleasing, and mechanical function. Pretty intuitive reasons of what you would want in a good prosthetic device. But just review those and see why those would be important to the patient. So these were the types of prosthesis that she talked about. So you have transtibial, which is below the knee, above the knee, transfemoral, and then below the elbow, transradial, above the elbow, and transhumeral. Well, these aren't necessarily too important, but just know the difference. It's pretty intuitive based on transtibial. Think where the bone is, and think about where the replacement would be. Okay, she talked about two types of attachments. Synplasty, which was typical of use, in the early 1900s, mid-1900s, a little archaic now. And what she mentioned about synplasty, it was basically you would wear, multiple straps and harnesses to keep the prosthetic on. Pretty archaic technology at that point, and now moving forward 20 years, they started doing osseointegration. So know about osseointegration. Know that basically what you have is they use the stump, it's called, so the portion of the bone that's still exposed, oops, sorry. So the portion of the bone that's still exposed on the stump, they use that as an attachment site for the prosthetic. And also know that that is a place of common infection, because think about it, when you have the prosthetic on and it's connecting to the stump bone, there's going to be constant rubbing, etc., which can lead to ulcers and constant open wounds in that area, which can lead to infection. Okay, we just went over this a little bit. So the socket is the portion of the prosthetic limb that's going to fit into the stump, which is the end of the residual limb, and the fit of the socket is important, like I said, because due to rubbing, sharing of the skin, and the infection site can be due to rubbing of the residual skin. So attachment mechanisms, this isn't too important, but just know that they have suction straps, harnesses, etc. You want that snug fit to prevent constant rubbing, and It's consists of like the large hollow part that would extend onto, you know, the portion of the shoulder that's still connected, or the portion of the femur, tibia, etc., depending on the location of the prosthetic. Okay, so these are the two types, two or three types of upper limb prosthesis that she discussed. So one was the externally powered one, and to know that there was grip strength, so they had the strength, that's like the picture up at the top. However, it was tough to control. So remember she talked about, you know, you have to learn to move your muscles in, you know, the correct orientation to make a contraction, make a neural impulse in order to get the prosthesis to move. And then she talked about myoelectric, which is kind of the most current use of prosthetics at this point. And again, using the contraction signals, but however, that detects the electrical impulses that are extending from the stump of the limb, and in order to make the prosthetic move. And surface electrodes on that part in order to receive the stimulant. And then switch controlled are kind of the archaic that she talked about. Those were kind of the first segue into actual movement with the limb. And those were activated by actual switches for each digit. So those were less expensive. Today, the standard is myoelectric. And then iLimb she talked about, so that's the bionic hand. Know what iLimb is, and it costs anywhere from $50,000 to $80,000, and only in 400 patients so far, so it's pretty new technology. And this is just an example of the iLimb, and as you can see with the iLimb, you have much more control over the digits. And she also mentioned that the thumb sometimes is not movable. That's one of the issues of getting the neural impulse to the thumb. So sometimes that has to be manually moved, but the newer technology is having the thumb move with neural impulses as well. Okay, and this is, she talked about closing the loop. This is important. I would know these three different types. I know it seems a little nitpicky, but they're pretty important. So you can have one where she mentioned that you integrate directly into the residual nerves that are leading to the brain. And then the next one is, so what if there wasn't any part of the humerus left in order to get the electrical impulses from? Then you can reroute an electrical signal into the chest and recruit neurons from the chest in order to make muscle movements, to have neural impulses actually control the arm from the chest. And then the final one is where they reroute it outside. So she mentioned that you can take neurons and basically run up and through your neck, behind your ear, over into your scalp, and actually directly connect from the limb to the head. So just know the difference. So one is directly connected to the neurons in the arm, one's routed in the chest, and the other one is routed through the brain and right directly into the brain. Okay, so surface mounted prosthesis. So we talked about this a little with infection. So this compression on the skin, the shearing, is rubbing, is pain, fork fit. Not necessary to know all these, but just know, some of the common issues they have with the attachment site. That's it. Any questions?
Okay, my turn. I'll be discussing the biopharmaceutical lecture as well as both of the cardiovascular things. I just want to let you guys know we all appreciate your dedication to photographing us. It's really great. Thank you. Okay, so talk about biopharmaceuticals and personalized medicine. So it's not a spectrum, it's not a binary, right? You have your general medicines, you can throw ibuprofen, you can throw Advil, tons of people, but you can only throw Gleevec or some of these other things that like a small subset of people. And that's where the spectrum is, and then there's stuff in between. Okay, I really love this slide, it's just so great. Cytokines. Okay, biopharmaceuticals, this is a definition. You really should know it just so everything past this makes sense, right? We're not going to ask you to write this out or recite it or act it out, just understand it and know what it is. So, I remember back, in the FDA lectures way back when, we talked about generics and how stuff goes off patent and that works. So there's a similar thing for biopharmaceuticals that aren't just drugs, right? So for biopharmaceuticals, instead of calling it a generic, you call it a follow-on biologic